right. So next we have Dr. Jenna Smith-Turchyn from McMaster University.
Hi everyone, thanks so much for having me here today. I'm Jenna Smith-Turchyn. I'm a physiotherapist and assistant professor at McMaster in the School of Rehabilitation Science. And I'm here today to tell you about a project that was jointly funded by Sepsis Canada and the Canadian Frailty Network, titled Exploring the Intersection of Cancer, Sepsis, and Frailty, a scoping review. So a little bit of background. We know that cancer, sepsis, and frailty are common conditions that affect many Canadians. We also know that cancer increases the risk of sepsis. Cancer survivors are at double the risk of developing sepsis compared to those with no history of cancer. We also know that frailty is a common consequence of cancer treatments. About 50% of adult cancer survivors are in a state of frailty or pre-frailty. And cancer treatments are said to accelerate the natural aging process. In terms of frailty, we know that pre-existing frailty can also lead to poor outcomes in both cancer and in sepsis. So thinking specifically about cancer, frailty prior to a cancer diagnosis leads to more post-op complications, lower levels of chemotherapy completion rates, as well as long-term functional outcomes that are poor. Frailty prior to a sepsis diagnosis also leads to worse clinical outcomes, increases in mortality, and decreases in return to home. While it's clear that there's an interaction between these conditions individually, the interaction of sepsis, cancer, and frailty has not been well explored in the literature. Therefore, the purpose of our review was to explore the intersection of cancer, sepsis, and frailty and consider management strategies to improve survivor outcomes. So our three research questions were: what evidence exists describing the interaction of cancer, sepsis, and frailty? How is the interaction among these three conditions described in the literature? And is there evidence to support an interactive effect of these conditions on one another? So in order to answer these research questions, we again conducted a scoping review that was guided by the Joanna Briggs Institute framework. We conducted a search in 7 databases, and we did duplicate title and abstract, full text and screening, and data extraction. We took all of the extracted data and did a qualitative synthesis of the information and used descriptive statistics where available. So looking at the Prisma flow diagram there, we identified just over 2,000 references on our initial searches. And after duplicates were removed and we went through the screening process, we had 18 studies that were included in our review. In terms of results, we categorized everything based on research context, population characteristics, and the major concepts that were explored. So looking at research context, all of the studies included our review were observational studies, a retrospective analysis of 3 major data sets that were available from the United States, and most were published since 2020, so quite recent data here. In terms of population, our included studies represented over 3.2 million participants, with an age range between 18 and 93, and a fairly equal distribution of male and female participants. In terms of cancer characteristics, there's a lot of variability in cancer site, mostly solid tumor cancers, which was led by head and neck cancer, followed by bladder, brain, and colorectal cancers. Most of the included studies evaluated participants around the surgical stage of treatment, so 1 month post-op up to a year post-op. In terms of the major concepts explored, so starting with frailty, 78% of studies, so most studies did explicitly define frailty, relating to that increased vulnerability to stressors and decreases in physiological reserve. Although it was pretty well defined and consistently defined, there was a wide variety of frailty measures used, so 12 unique measures total, with the 5-item modified frailty index being the most commonly used. Sepsis as a concept and condition was not well defined, however. Only 2 of our included studies did provide a definition of sepsis, and it was defined using the Sepsis 2 criteria. In terms of the information provided about sepsis, it was usually only a count or frequency of occurrences. When looking at the interaction, all but one study examined the effects of frailty on sepsis occurrence in cancer survivors. And 71% of these studies found that higher frailty levels were associated with higher rates of sepsis in cancer survivors. So in terms of how we're using this information and what we're doing next, so while the definition of frailty was consistent between studies, again, the measure used to assess frailty was not consistent. So we need to take these frailty measures and provide recommendations based on assessment on the most appropriate to use in those with cancer and sepsis at different ages and stages. So thinking about those psychometric properties, the usability and feasibility of them in a clinical setting. Secondly, that lack of reporting on sepsis characteristics, so specifically the source and the etiology, needs to be improved. So we need more detailed reporting in order to determine risk, potential adverse events, and identify strategies to improve survivor outcomes. And lastly, as a physiotherapist, I'm very interested in determining the effects of different rehab strategies to improve survivor outcomes. In those with the conditions together and also in sepsis alone. So what do we do in order to prevent it? But not just the what, but who may benefit most and at what time. So when is the best time to intervene? So really thinking about triaging our management strategies based on need. And I'd like to thank my study team, and I'm happy to take any questions.
All right, thank you very much, Dr. Smith-Turchyn. Are there any questions for her? No? Oh, Allison has a question.
Running away quickly.
So, Jenna, when you finish your scoping review, what do you think the next step is?
Yeah, so what we're doing right now, we are interviewing individuals who have sepsis and cancer to determine need based on rehab. So what rehab have they received? What did they feel would be useful during and after their diagnosis and subsequent treatment? So patients, caregivers, and healthcare professionals we're interviewing. And we're hoping to create some educational modules just to give basic information that comes forward in those interviews. And then I would love to pilot a rehab strategy for this population based on those findings in the near future. Mm-hmm.
In your presentation, but what exactly are those 12 characteristics of frailty? Could you elaborate just a bit on some of them?
Well, it is different depending on where you look, but Fried did have a frailty phenotype that he developed, and those 5 characteristics of that phenotype are low physical activity level, weight loss, decrease in muscle strength, did I already say low levels of physical activity, increased fatigue, and I think it was decreased walking speed is the 5th one.
Sure, okay,
So if you have 3 of 5 of those, you're said to be frail. 1 or 2 is a pre-frail state. Mm-hmm. Yeah.
Thanks, Jenna. Just to follow up to that, questions about frailty. Obviously, frailty tends to affect the elderly mostly,
Yeah.
but it can also affect anyone, like you said, who may have cancer as well. In your review, did you find any age group? Because sepsis affects individuals at extreme ages. So
Yes.
was it mostly those that were frail, or did age have a factor in this?
Age does still tend to have a factor in this, so people who are older are more likely to have frailty, but especially in the cancer populations, we see this happening much, much younger. And so that's why there's a problem with some of these frailty measures as well, because they've been looked at in older adults, but not so much in younger populations. And for young adults who have cancer, so that's considered anyone over 40, within the next 10 years, a third of those individuals are said to be in a state of frailty. So that's quite a high number at a younger age. So hopefully that answered your question, but age does have a factor, but with these conditions, we see it happening sooner.
Just a thought.
Yeah.
If one is willing to accept an administrative definition for frailty and sepsis and cancer diagnosis, I think this is a very good question to ask one of our provincial data sets. And have some algorithms to define sepsis, of course, but frailty. So maybe
Wonderful.
consider.
Yeah, great suggestion. Thank you.